All right, we're going.
I'll set the slides.
All right. We are going live now. It should. Yep, we're live.
Good evening. This is school committee member John Monfredo, filling in for Mayor Petty, who was on vacation. I'd like to call a meeting to order. This is a very special school committee meeting to listen to a distinguished panel of medical experts here to answer questions on the coronavirus and its impact on the reopening of school. These questions were submitted by the public to administration this week. The presentation will go until 7 o'clock. Please first stand for the Pledge of Allegiance.
I'm not on camera, no. I can. Thank you.
I pledge allegiance
to the flag
of the United States of America and to the
and to the republic
for which
for
it
which
stands,
stands
one
one
nation,
nation,
under
under God,
indivisible,
indivisible, with
with liberty
liberty,
and justice
justice
for all.
for all.
Dr. Friel, please call the roll.
Ms. Biancaria? Here. Mrs. Clancy? Here. Ms. McCullough? Here. Ms. Novick?
Here.
Mayor Petty? And the acting vice chair Monfredo.
Here. Under general rules 0-237, featuring the panel tonight, I would now ask Superintendent Benenda to address the purpose of tonight's meeting and to introduce our panel. Superintendent Benenda.
Good evening, everyone. I'm very excited that we're able to present to you this great panel. This is a great and it's a very unique opportunity for our medical partners that provide us lots of information as we do every single week regarding what is the best guidance for the health of our students, our family. I really want to personally thank them for participating in this medical forum, taking time away from their practices and serving their patients to come with us here tonight. I want to thank them for their passion and their dedication to the health of all our students, staff, and families. So I'd like now to introduce to you Dr. Linda Young, who will be our facilitator for tonight.
Thank you, Maureen, and welcome everyone to our virtual medical forum. Thanks for submitting your questions. We will not be repeating these questions verbatim, but instead we'll prioritize the ones that we as physicians can answer before we end tonight at 7. There are questions about the design of the model, the hybrid options, which we will defer to the administrators in district. Also, questions concerning cleaning, ventilation, and HVAC. We're not experts in these areas, but the Massachusetts Department of Elementary and Secondary Education has very good guidelines, which the district will follow. I'd also like to thank the members of the Worcester School Committee for joining us today and for the work that they do. And if I could have the slide that Maureen has with our panel, I'd like to introduce them.
First, we need to do the interpretation instructions.
Okay.
So leave those up for a second.
So if you want to hear this meeting in another language, please click on the interpretation at the bottom of the screen.
And there's also closed captioning.
I'd like to thank our school committee members, Mayor Joe Petty, Diane Interior, Laura Clancy, John Foley, Molly McCullough, John Monfredo, and Tracy O'Connell-Novick, and also our assistant to the superintendent and clerk of the school committee, Dr. Helen Friel. So as you see here, this is the format for tonight. As Dr. Young shared with you, these are questions that have been collected on the website. We put them into themes, and the panelist has prepared answers that will be presented tonight.
So I'll introduce our medical panel. I'm Dr. Linda Young. I'm a retired pediatrician in Worcester, past president of the Mass Medical Society and the Massachusetts chapter of the American Academy of Pediatrics. We also have Dr. Mary Beth Mioto, who is an Associate Medical Director of Pediatric Population Health at the Family Health Center of Worcester and current Vice President of the Massachusetts chapter of the American Academy of Pediatrics. Also, Dr. Michael Hirsch, the Medical Director of the Worcester Department of Public Health. He's a pediatric surgeon at UMass Memorial Children's Medical School and a professor at the medical school. And Dr. Beverly Nazarian, who is the Worcester Public School physician consultant. She is a practicing pediatrician at UMass and an associate professor at the medical school. We have also Dr. Lloyd Fischer, a pediatrician at Reliant Medical Group. He's the chief of the Division of Community Pediatrics at UMass Medical School and current president of the Massachusetts chapter of the American Academy of Pediatrics and an assistant professor of pediatrics at UMass. And also we have Tina Hermos, pediatric infectious disease specialist and an assistant professor at the medical school. Thank you. Whoop, not yet. So our questions, our first set of questions are going to be addressed by Bev Nazarian. So Bev, if you could please take over.
Thank you for allowing us to speak with you tonight. The first questions I'm going to address are a group of three that are sort of broader questions. We've had the question, why don't we just start completely remote with opening schools? We've also had other people ask the opposite question, why bother with a hybrid? Why don't we just get everyone back in school? And then the third one, which is dear to me as a mom, is what would you do with your child? Would you send them to school? So I think as a group here of pediatricians, what we've recommend is that as many children as safely can be returned to school would be the ideal. However, the emphasis on that is really safety. And currently in Massachusetts, with our low infection rates, and then with a plan for this idea of layering and adding safety to school, which includes masking children, it includes distancing, it includes extra hand washing, it includes having smaller cohorts where your kids are seeing 12 to 15 other students and not the whole school. We feel like with these things in place, that there can be a safe return to school for our students and for our teachers and for our staff. Now, as far as the model goes, there are some limiting factors which are district dependent, and we're going to defer to the district, but I think that in a district like Worcester, things that will influence the model are how many kids can we fit in a small classroom and have adequate spacing? Do we have space on the buses for kids to be, to be safely apart? Some of those considerations. So those things are going to come into play when they're trying to decide on the model. Looking at this from the standpoint of my child, I have a rising sixth grader, and if I am offered an in-person option for my child, I feel right now that I feel I can do that safely because I know that the schools are putting all these layers in place that are safe for my child. And I also feel confident in our get upward if we're starting to see increased infection. I know they have our back. I know they're monitoring this closely, and that if there's an issue, then we have the ability to pivot to remote. So with that in mind, I think what our goals tonight in joining you all is to not tell you that, what you should do for your child. I think we really recognize that this is something that's a really individual decision, and that there are families that may have elderly grandparents living with them. There are people that have various health conditions. And so our goal in coming here tonight is to give you the best information we can with what we know now. And I think when we're dealing with COVID, this is something that is, that we are getting new information every day. So with that, I'm gonna next move on to Lloyd Fischer, and the questions that Lloyd will be taking on are some questions about why are we able to open up now? Why, when we were closing in March, what's different overall? There's been comments about increasing cases in Worcester. Is it safe to open if there are increasing cases? And so I'm going to let Lloyd address those questions. Thank you.
Thank you, Bev, and thank you to the members of the school committee and teachers and parents and others who are part of the Worcester Public School community. As a practicing pediatrician in the city of Worcester, many of the children in my practice attend the public schools, so this is something that is very important to me to make sure that we are providing all of the information that we possibly can so that people can feel comfortable about the decisions that are being made. So as Bev said, that I'm going to be addressing some of the questions that came in related to what is different now as compared to March when the decision was made to close schools. Back in March, we knew very little about this disease. It was still a new entity. We didn't have any treatments that we knew what to do with, and we were very concerned about hospitals and ICUs reaching capacity and us being unable to care for the number of patients who would need care, both for COVID as well as for the other medical conditions that they may seek care for. We also didn't understand much about how this disease spread, and we had very little information about what we can do to protect ourselves from contracting the illness and from spreading it to others. Since that time, we have learned a great deal. Because of all the efforts that were put in place, we have done an excellent job of slowing spread to the point that our hospitals have significant capacity now. In fact, there are very few hospitalized patients in the city of Worcester with COVID, and even across the state, there are far fewer patients. We also have a better understanding of how we can treat this disease, especially in the most critical patients. And we have a good understanding of who is at most risk for both contracting the disease, for developing significant and severe complications from the disease, and also who is more likely to spread it. Because of that, and what we've seen this impact on children, and that the fact that we have been able to show through multiple studies and multiple experiences that people both in this state, in the country, and really across the world have had, and we know that children are less impacted in terms of their ability to even get sick with this, and when they are sick, how severe the symptoms are. And we have more and more evidence showing that children, especially younger children, are less likely to even spread this. So because of that, things are very different now than they were back in March when the decision was initially made. We also have far better access to testing than we did back then, where the test was brand new. We didn't know what a test even meant or how to access it. Now there's far better access to testing. We have far better access to personal protection equipment, or PPE. So that's the masks and other equipment that are used to slow the spread of the disease. Because of that, those of us who have been working through the pandemic and have been interacting with people in our own professions have gained a much better understanding what we needed to do to keep ourselves safe and to keep everyone around us safe. And we can use that information, and that's what these guidelines that are that were produced by the Department of Education and are now being implemented in the various districts have done. There was a few questions about the the recent reports about a rise recently in the city of Worcester, and that is absolutely true. There has been a very slight increase. We got to keep in mind that the total number of new cases have decreased dramatically over the past couple of months. So while there is this slight increase, we don't know yet if this is going to be something that is sustained or really significant. We also have not seen an increase in the hospitalizations or severe illnesses. So we are doing a lot more testing. So that does indicate a reason why we may see some of the increase in the tests, in the positive cases. That being said, as Dr. Nazarian mentioned a few minutes ago, these guidelines were written so that we can really quickly change what we're doing if in fact we enter an unfortunate situation where we see a significant increase in cases. We also have to keep in mind that even if there is some increase in cases in the community, that does not necessarily mean that there is spread in the school. And we have better methods to monitor that. And if in fact there is spread in the community, but not in the school, that also gives us more comfort and more feelings of safety. But this is definitely something that our public health colleagues are going to be monitoring very closely. And we, of course, will be making recommendations and changes in the model that all the districts are using if in fact we see a significant and a sustained increase in cases. That also brings to the point that we are all in this together, and we all need to do everything we can to limit our spread outside of the schools. We believe from all the evidence that spread in the schools is not a significant factor. It's what happens outside of the schools. So we need to be wearing masks. We need to be practicing appropriate physical distancing outside the schools, because we don't want to see an increase in community rise, because we don't want to put all of these efforts in jeopardy, because as others have said, we all believe strongly that it is critically important to get our children back to in-person learning as much as possible. So that really covers, there were a number of questions on those topics, and I hope I was able to answer that particular area. And I'm going to move things along now to Dr. Tina Hermos to really talk about some of the questions that came in regarding transmission of this disease.
Thank you, Lloyd. Thank you so much for having me. This is such an important meeting, and I feel honored to be here. Even though it wasn't a question directed to me, I did just want to add that I'm the mother of 3 two 10-year-olds and a 7-year-old, and I will feel very comfortable getting them back into the classroom based on what we know and what we can provide for them in terms of safety in the public school setting. So there were a number of questions about research studies on school transmission and transmission by children in general, particularly younger kids versus older kids. So again, such an important question, and we're learning more every day. The data we have is from contact tracing studies where, one child is test positive or is sick, and we want to see where that virus came from and where it spread to. And these studies are coming in from the US and from many, many other countries. And the data is very encouraging. So first of all, as Dr. Fischer mentioned, we know that children under 18 are less likely to get sick from the SARS-CoV-2 virus, the COVID-19 virus. So between 1/3 and 1/2 as likely to get sick compared to adults. So they're less likely to contract the virus. In the United States, children under 18 represent about 22% of the population, but they've only accounted for about 2% of all cases. So they're very much less likely to get sick. And that's distinct from other respiratory viruses that we're used to. So this is sort of new for us. And as Dr. Fischer was saying, back in March, we didn't know. We thought maybe children would be little petri dishes who were spreading it to all their family members. And we've just learned so much in the last few months that this is not the case, specifically for this virus. But it is similar to the other coronavirus reported a few years ago in the Middle East. So we have a standard to compare it to. So less likely to get sick from the virus, but how likely are they to transmit it to others? And again, what we're learning is encouraging. There are about 9 big studies describing this, and I decided just to pick 3 examples to share with you, which I think are very illustrative of what's happening, to tell us a good story. So there was one study out of Australia, and this looked at 18 individuals in the schools who tested positive for the COVID-19 virus. And this was reported back in April. So this is as the virus was surging and before the schools were closed and before we knew anything about precautions. So before any of the children were told to wear masks or distance or even excess hand washing or anything like that. So they looked at these 18 individuals in the schools made up of students and staff and high school students and younger students. And what they found was out of all the contacts in the high schools, 695 contacts from the high school students and staff who had tested positive, only one contracted the virus. And of the lower school, in the lower elementary schools, only 1 of 168 people tested positive. So they found that there was only a 0.3% chance of the virus being spread. And again, we feel that this is less likely to be from children, and more likely the adults are more likely to spread the virus. So that's very strong data that children were not spreading it to their classmates in any large capacity. The second example I wanted to share was we have 2 countries right next to each other, Finland and Sweden, who had drastically different policies. While Finland shut all their schools back in March, Sweden did not. And Sweden did not shut down their businesses the way many countries did. It was controversial, but they didn't. And they did have many, many more cases in Sweden, in their country. They had 5 times more cases, but the incidence in children less than 19 was no higher than their neighbor in Finland that did shut down the schools. So when they looked at the COVID cases in a country that didn't shut down the schools, it was the same as in the country that did shut down the schools. And then they looked at cases in teachers, and they didn't find any increased number of cases in teachers in this country that didn't shut down the schools. And then the third example, just to bring it closer to home, is that we have been running emergency childcare centers throughout this pandemic. Everybody here knows probably that New York was one of our leading sites where 800 cases a day were being diagnosed just in a single city. My sister is a single mother who sent her child to an emergency childcare center. She's a medical professional frontline worker. And there were 40,000 children in settings like this across the country, and there were no reported outbreaks or clusters. So this is a quote from an NPR article. The YMCA of the USA and New York City's Department of Education have been caring for collectively tens of thousands of children since March, and both tell NPR they have no reports of coronavirus clusters or outbreaks. So I just wanted to share those 3 examples with you about the transmission. And I am not saying it could never happen. We're not saying that there's something magical about children, that they cannot transmit this. It just seems to be less likely. And with the layers of protection that we know we can provide in a school setting, then I feel that the incidence of children spreading it to their classmates and their teachers can be very, very minimal. And Dr. Fischer mentioned the adults in these school communities are going to be the bigger risk to each other, and that we all have to act like part of a larger community and take the precautions when we're going to the grocery stores so we don't infect our own children, we don't infect our colleagues, that teachers don't infect their colleagues. And then I will just go on for 1 minute because there was a specific question about a New York Times article in July 19th that the headline said that children over 10 are just as likely to transmit as adults. So not to get too technical, but I just wanted to describe where that headline came from. It was a study from South Korea where they looked at the children who had tested positive. There were about 120 of them. And then they tested household members. And they found that about 18% of the household members of children between 10 and 19 did test positive. So the 2 things I think that are important to recognize about that is that there was no proof of which direction the virus went. Did the virus go from the child to the adult in the household or the other way around? So the study did not differentiate which direction that virus went. And again, these are household members. This wasn't a school study. This was people living and sleeping together. So about 18% was what they found in people who are living and sleeping together without masks and without the school precautions. The second thing about that study is they did look at 10 to 19. So there was no information about children 10 to 12, 12 to 15, 15 to 19. So we don't know from that study where the breaking point is. We do know that as children start to look and act more like adults, they probably transmit this virus more like adults. But there's no magic age where they just automatically start transmitting this virus just like adults. It seems to be less likely in younger children, still less likely in the middle school age children. We can't give you a percent, and it gets more similar to adults as children look, gain the same size, lung size, their physiology, their bodies are more like adults. It seems like that's the case. That is my answer for those questions.
Thank you, Tina. You had mentioned about how to keep safe, so I'm going to redirect our conversation, and we have some people that are going to cover the questions about masks and social distancing. So I'm going to start off with Mary Beth, please.
Thank you, Linda. I want to say also, I have an 18-year-old, so I might have some of the oldest kids in this group. And my 18-year-old will be attending school in the fall. And he's very excited about that. One of the biggest changes we've all experienced in the past 5 months is the appearance of masks in everyday life. And so it's not a surprise that a lot of you asked many questions about masks. And that's a big part of what we think is going to provide a safety net for teachers and students in the school. So I wanted to take a few of those questions. Children 2nd grade or older will be wearing masks during the day, and all children should be wearing masks to some extent on the buses. And that's what I wanted to talk about. Some of the parents and teachers asked, what's reasonable for children wearing masks? And I think as pediatricians, we see a lot of the developmental side of it, a lot of practical tips, because that's what we do best. So of course we know as parents that wearing masks is a huge adjustment. It is for adults, it's for kids. How will younger children keep their masks on the bus and other elementary school students learn to tolerate mask wearing? And that's where we as adults have a lot of opportunities to model mask wearing. It won't be an overnight adjustment, and every pediatrician, teacher, school nurse, principal, parent knows that we're going to have to work together with kids to help them do it. And so we actually, again, have been seeing kids in our offices since March, all of us, and we've been working with kids on how to do it and seeing. Some of the tips to make mask wearing successful: children will get used to wearing a mask just like they got used to wearing a seatbelt or brushing their teeth. And believe me, I grew up in that era where people switched to wearing seatbelts, and it was a new thing, and we all got used to it. And in fact, what happens now is we pediatricians and teachers tell the kids to make sure mom and dad wear the seatbelt. So don't be surprised if your child starts telling you that you weren't wearing their mask. One of the things that we want to be doing when we're about 30 days out, which we're pretty close to getting through the summer, halfway through the summer, is thinking about how long it takes to develop a new habit or skill. And a good time to start masking practice is actually now, because then you can be relaxed and think about it in a positive way, and that's going to transmit to your kids. Trying to start mask wearing on the first day of school is not something I would recommend personally. This week, I would talk to my child about masking, show your child a mask that you think that you would wear, and explain why it's important, how it can keep everyone safe and healthy, and help them get back to regular activities like school. Most of the kids I talk to actually do want to get back to school, so you can use that. Isn't that crazy? They want to get back to school. Involve your children in choosing their own mask. A 2nd grader may be much more interested in masking with a frozen mask with Olaf and Anna than a plain black mask. And a middle schooler might want a denim mask or something with the solar system. Some kids might want to decorate their mask with markers, take photos with them, and celebrate their fun creations. On the first day, you check out how much the child can tolerate the mask. So again, you can make this fun, because you're trying to figure out if that mask fits comfortably so it can be worn during the day. But to do that, let's see what kids do. They play around, they jump up and down, they talk, they yell, all of which you can do in a mask. And I actually do that in my office with kids. Is the mask staying in place? How comfortable is the child? You're listening to those cues. You might need to switch up the kind of mask or the way the straps are. If the child complains of the feel or fit, don't get upset, just try adjusting it or trying a different type of mask. Don't worry if the child is constantly touching and adjusting the mask. That was one of the questions, is that I think my kid is just going to touch it all the time. And I would say that's normal. They're going to, it's something new. And as time goes on though, just like we get used to wearing a seatbelt and it sort of feels wiggly at first, they will adjust to wearing the mask and the touching will get better. I personally went from wearing a mask very infrequently in my office, almost never, to all day, every day. And I found that I stopped touching it at all after about 2 days. So it just becomes part of your regular routine. So I think that parents can model that. Make stories out of the masks. You know, if anybody comes to Queen Street and sees me, I'll be talking about how vaccines are superpowers and special shields, and kids really respond to that. And this is the same with masking. Start slowly, as I said, have your child wear it for 5 minutes of indoor activity. Maybe you can get to 3 times a day for a day or two. Over the course of the month, you can work up to 10 minutes 3 times a day, and it will keep moving up, praising any efforts. Many kids will learn this skill pretty well at home by the time they come back. Some of them will improve way more when they see all their friends doing the same thing. You know, social pressure in this way is a really good thing. And the teachers and nurses will be wearing masks. They'll probably have fun discussions about how they chose the mask and what feels good about it. And they're going to be helping these children. We do not expect that children will be perfectly sitting still wearing their mask like robots all day. You know that the teachers that your children have known forever and the school nurses will be working on that. And I do want to reinforce that it's really more important to wear some type of face covering over the nose and mouth than to worry about a specific type of mask. So those questions about what's the best, we haven't seen in the community setting that the difference is really anything to worry about. Now, if you're in the hospital setting or in the office setting with every day I see a lot of sick kids, I might use a different mask. But really just covering the face in a way that keeps them most likely to keep it on, that's going to be the most important. So you don't have to stress out about that. One of the questions was, are there conditions for which masking is dangerous and should be discouraged? There are really less than a handful of medical problems that any general pediatrician or specialist could come up with that would cause a pediatrician to discourage mask use. In fact, children with things like asthma, allergies, and almost every medical concern will do better wearing masks to improve that classroom environment, improve their chances of the whole cohort staying healthy. And that's one of those things that when we talk about conversations, I would really encourage you to make special efforts, if you have questions, to speak to your own pediatrician or family doctor. That goes for adults who are teachers. These are the kind of conversations that we as a community should be expecting. And if we do, then we can all expect as a community to see pretty much all kids wearing masks. Another question is, what happens if my child's mask gets wet because he sneezed too much, it gets really dirty, it falls down, the strap breaks, all the things that kids can do to masks. And nobody in this panel would say that kids will not do amazing things with masks. And the great thing is that if a mask falls down or the children need extra mask breaks or extra masks, there is still, first of all, a lot of distancing. And that's a built-in multi-layer protection system. We have the distancing. We're going to have other pieces, hand washing to keep them safe, as well as the school nurses and the teachers have some extra masks for the kids. So you may think that the mask is great, the strap breaks, your child will be safe. And I want you to feel that the nurses and the teachers are there to help your child succeed, just like they are in everything else. Special ed teachers and nurses will be working on masking with behavioral learning and medical needs. Maybe not all kids can do that, But again, I work, about half my practice is with children with these special needs. And I've actually been surprised. The great thing about being a pediatrician is I'm always surprised by kids and how strong they are. And I have some children with autism who have been really impressed that they actually love masks. And so I think that, and we've been trying to require them during doctor's visits, some of them do well, and your special education staff will either work with them on masks, or again, there will be different precautions to keep everybody, including the teachers, safe. So really just wanted to say that this is the opportunity we have in the month of the end of July to make masking, which we do know from lots of scientific evidence is helpful. We can make this an easy transition, and working with the social distancing and the other issues, we can make everybody much safer. So for those who don't mask, there'll be other adjustments, and one of those is the distancing. And so I'm going to pass it on to Lloyd, who will answer some questions about distancing.
Thank you, Mary Beth. Before I move on to the distancing, I actually just wanted to share a couple personal experiences about masking. I too have been actually very impressed and somewhat surprised at how good the children that are in my office every day have been with wearing masks. And I recognize that that's a relatively short time period compared to what happens in the school setting where they're going to be wearing masks all day. That being said, I have 3 children who will be attending public school this fall, and I'm very excited and hopeful that they will return in person. I'm very comfortable with them returning in person. My children are entering 2nd, 4th, and 7th grade, so sort of spanning a variety of ages. And I have been amazed at their ability to wear masks for a prolonged period of time. When I first told them when the guidelines from the state came out and I realized that masking was going to be a requirement, I asked them one day at breakfast, I said, so if you can return to school in person in the fall, but you have to wear a mask all day long in school, what would you do? And it was under a second. Simultaneously, in unison, all 3 of them said, we will absolutely wear a mask if it gets us back to school. They really wanted to be in school. And we've been doing exactly what Mary Beth described, which is everywhere we go, we're using masks. I've been, periodically taking the children into supermarkets. My 7-year-old son loves to go to Lowe's. So we've been making some Lowe's trips, and he sees me wearing a mask. He's wearing a mask. And in fact, my 9-year-old daughter seems to forget she's wearing a mask. And on a number of occasions, we've gotten into the car and either my wife or I have turned to her and said, hey, you can take your mask off now. And she says, oh, I completely forgot I was wearing it. And I think that's something that we've all realized, sort of, as for those of us who have been wearing masks for 8 to 10 hours a day, every day for the last few months, it really just becomes second nature. And I just don't even think about it anymore. And so I definitely am talking to all my patients, and in my role in the mask chapter of the AAP, I'm encouraging all pediatricians in the state to make this just a standard part of what we talk about at every visit. And it's to go over masking and practicing and all the things we can do to get our children comfortable. So moving on to distancing. So there were a lot of questions, and there's always been a lot of confusion about the distance between 3 feet and 6 feet. And we keep hearing 6 feet, 6 feet, 6 feet. And why all of a sudden are now we saying that it's going to be between 3 and 6 feet? And I think one of the things to remember is that the goals are, of course, to maintain 6 feet if possible. But when we actually look at the studies and we look at how far transmission does occur, there hasn't been shown to be a dramatic difference or a significant benefit in the difference between 3 and 6 feet. The 6 feet guidelines were really something developed in a medical setting, where you have patients who are potentially sick or even very sick, and a sick patient is going to spread virus more likely than those who are asymptomatic or mildly symptomatic, which is what we're going to be dealing with in the school setting. And when we look at the benefits of going from 3 to 6 feet, and you balance that with the potential risk and harm of not being able to educate as many children in person, that there's just not enough benefit from going to 3 to 6 feet. The other thing to keep in mind is that the guidance about that 6 feet was always, we obviously want to do it as best as possible, but it's 6 feet when you can't be masked. And this is where the multiple layers of protection and the multiple efforts that are in the guidance that all of the districts are going to need to maintain really come into play. So we have masking, we have distancing, we have good hand hygiene, which we know is critically important, and we want everyone in the community, and this is where we depend on our parents of the school children to be diligent, is keep your children home if they're sick. We always send the children in if they have mild illnesses, we think they're fine, and this is not the time to do that. We have to keep the children home. So by taking out the sick children from the schools, by having multiple layers of protection, we're not dependent on any one thing. So because the times that we are less than 6 feet, when we're somewhere between 3 and 6 feet, the children are also going to be wearing masks. That's where we can feel safe about this. So that brings up a question that came up about lunch. There were a few questions about, well, how's lunch going to work? During lunch, obviously masks are not going to be worn. And during lunch, there is going to be a distance of 6 feet. And that we know is logistically difficult, and that is partially the limiting factor in how many students can be in the school at one time. And I know many districts are coming up with very creative ideas of how to space out the children during the lunch period. But we do feel that because one of those layers of protection will not be maintained, the masking, we then need to be more aggressive about the distancing during that time. Also important to keep in mind that during this whole pandemic, the World Health Organization, the WHO, has always recommended 1 meter, which is just over 3 feet. And many of the schools across the world in the European countries have always had a distancing of that 1 meter, which again is very close to 3 feet. And there really hasn't been shown that going down to 3 meters in a school setting has been a significant problem or has caused any increase in transmission. So that, again, is why we all feel very comfortable that this is an appropriate method of distancing. And then finally, I'll just talk about buses, because there were a few questions about, well, how do we maintain distance on buses? So this is why children of all ages, are down to even the preschoolers on buses, are going to be wearing masks because they're going to be closer than 6 feet. But because of the way that the buses are going to be configured with 1 child per seat, they won't be closer than 3 feet, but they are going to be wearing masks, and they're all going to be doing their best to face forward. And of course, we know that these are children. They're not going to be 100% compliant and sitting straight forward, but we're all going to do our best. And this is where all of us, pediatricians, parents, teachers, everyone, bus drivers, are going to work together to try to work with our children to help them to be sitting forward, be wearing their mask, and again, with these multiple layers of protections and safety mechanisms, we are going to be able to keep everyone safe and keep transmission low in the school setting and in the transportation setting as well. So I'm going to pass things on to Bev Nazarian, who's going to talk about in-classroom considerations.
All right. And then I just wanted to make one comment, just following up on Lloyd's very briefly, is that there were several questions about kindergartners and first graders and preschoolers, and if they're wearing on the bus, why shouldn't they be wearing it in school? And I would say that I think all of us would wholeheartedly support preschoolers, kindergartners, and first graders wearing masks in school. I've seen in my office, the kids are able to do it. However, we totally recognize that age group is going to be a lot more challenging. So, but I think that is possible. So I think that certainly if you're a parent of kindergarten or first grader, encourage your kids to wear a mask. I think that, it's an extra layer of protection for them and their classmates. All right, as far as teacher, and classroom concerns, we had a lot of questions from teachers, and I recognize that those of us who are pediatricians, we see children and teenagers, and we really don't want to be people thinking that we don't care about the adults. I care dearly about the families in my practice, many of whom are teachers, and some of them are bus drivers, and we have these conversations all of the time. And I have friends who are teachers, and so I want to recognize that not only do we want students to be safe, but we want teachers and staff to be safe and to feel safe. And I know there's a ton of anxiety out there. And all I can say is that I can empathize with that. I do not teach in a classroom, but I have been seeing patients in my office where, for the last, since March. And I have to confess, when I was seeing patients early in this pandemic, I was afraid. I was really nervous about getting COVID. I was nervous about bringing it home to my family. I would sit there scrubbing my pen and the keyboard and, the light switch and everything. And, and I can tell you that now I don't do that. I feel really, really safe. I wear a surgical mask. My patients and their parents wear they wear a mask when they can. Some of them wear them on their heads. Some of them wear them other ways, but we try and do that. And I'm not in a classroom with 12 to 15 children for a long period of time, but I am in a room where I'm sitting, 3 feet away from not only a child, but an adult who transmits more easily. And I'm laying hands on kids to examine them. And I feel safe with that because I know that I'm going to wash my hands after. I know that I'm going to, I'm going to hand sanitize. I'm not going to touch my face. But I realize that that's something that, it feels really scary. And so teachers have asked questions like, can I go around the room? One of my friends asked, can I tie my first grade student's shoe? Can I reassure a kid when he is scared? And the answer to all that is an absolute yes. As we've heard from everyone else, the transmission risk is when you are up close for a longer period of time without a mask. And so you're allowed to do all of those things, just like I'm going up right to these kids and examining them, and laying hands on them overall. But I also recognize that it's going to feel really stressful at first. And I think that, again, to keep in mind these layers that are there and that, the kids are, we're sounding like a broken record, but the kids will be wearing masks, the teachers will be wearing masks. And I think the question is what should the teachers be wearing for masks? I think my recommendation would be surgical masks, which my understanding is the school will be providing. I would also say if there's a teacher that has a mask that they prefer, that they want to wear, if there's something that makes you feel more comfortable, then I would certainly support that. But I think that I would expect that the surgical mask that I wear in my encounters with patients, I would feel safe with that in the schools. There may be some teachers who are working with special populations where they have a lot more close contact with kids who may not be as good about wearing masks. And in those populations, and I'm thinking more of special education, you may need to increase your layers. That's where, and we're not going to go into a big thing about face shields and things, but to realize, there are other ways to add layers of protection. And then the final thing I just wanted to say is that, again, as been mentioned, the main risk of getting COVID in school is not going to be from the students, it's going to be from the other adults in the building. And so it can be really tempting to let your guard down. I think, if you have teachers' lounges and things like that, it's really important to wear the mask all the time and to maintain your distance from the other adults in the building. And so with that, one thing before I pass on to Mary Beth would be the other important thing is if you have any symptoms, if you have a cough, if you have a sore throat, if you have a fever, if you have any of the symptoms of COVID, even if they're mild, it is really important that you stay home as a teacher, because that's how we're going to decrease transmission. And with that, I'm going to hand it on to Mary Beth Nato, who's going to talk about when you keep your kids home. Thank you.
So the nice thing is that we have a great cadre of school nurses and teachers who I think are going to be educating families through this whole process. And there are very straightforward guidelines that are going to help the schools and that are also being used in our health centers. So these are not different standards. I got off phone calls today on school reopening, only to get on other phone calls about how we treat children who are sick, who are going to come to the health center to help you decide as a parent what should be done. And so we talk a lot about health citizenship as pediatricians right now. And if we're in a community and we're looking at community transmission, how can we lower that community transmission so we're all safer? And bottom line is, if everybody, not only parents, teachers, and children, are following the guidelines on crowds, where you should be spending your weekends, and different types of guidance on transmission rates, we will keep the transmission rate in Worcester, which is the most important because its community transmission is very local, down to a level that protects the community when the children return to the classroom. So just like I said, that trying to start masking right now, if you're able to, try to get together as a neighborhood and make a pact that your community is going to take it seriously, the health citizenship. And so that's one issue. We also want the children to get to school. Here we are all telling you that in-person schooling is good for their social emotional health, they'll learn better, and yet we also have to be careful about who goes to school, right? So I've been a parent of young children. All of us have that experience that we're sitting there saying, do we send our child to school if they complained last night of a fever or they have a stomach ache or something? If your child has any symptoms, and I'm not going to ask you to memorize them because your school nurses and everybody is going to be very helpful on that, but things like fever, runny nose, cough, headache, diarrhea, muscle aches, vomiting, stuffy nose, or really unexplained irritability, what do? You're going to, in this case, err on the side of keeping them home. And that is just such an important thing. And that's, as Bev said, it's also about adults doing the same thing. And you have a resource, you have a phone to call the school nurse who can really guide you on the steps you need to take. Think about it for a second, is that no matter what model we go into, we want to maximize the time the child is in school. And if families take that one day seriously when they are sick, then there's going to be a lot more days that they all can go to school because they're not spreading it to their cohort or pod. And I believe that Bev mentioned it a little bit, that you can think about this, is that you're not responsible and your child's not responsible for protecting himself from a whole crowd, the whole school, nor does he have to protect the whole crowd of people in the whole school. There's really nice pods or cohorts, and that's how you can engage your child too, and saying, we're going to keep you home because there's about 12 or 15 kids who you are now seeing every day. And we can keep you all healthier, as well as a teacher who's working closely with you. If today, because you had a cough, we get that checked out, we talk to the school nurse. So please be communicating really well to the school nurses, and they have just a priceless job right now. Finally, the whole family needs to wash their hands again. I think this is something that we should be teaching our children. We probably do teach our children, but this is any infectious disease, but especially for coronavirus. And I would echo what Bev said, which is I just wash my hands a lot in the exam room. I get hugs, I examine kids. I was afraid at first to give high fives. I give high fives, and guess what I do? I go right back to the sink or the hand sanitizer, and you can too. If you're doing all of those things, you're keeping your family clear of infection, and then that little pod family that your child is living at his school home. Follow the rules of the road. Just like you use seat belts and stop at red lights, don't go to big parties. That's all what we talk about with health citizenship, is that we're all making ourselves good citizens to keep each other healthy. There's one other really big thing to do for health citizenship to keep both students and teachers healthy and safe. And I'm going to pass it on to Mike to talk about one of the big things this season that we really want to make sure everybody does.
Thank you, Mary Beth. And thank you everyone for having me on this panel. I'm just so impressed at the breadth and depth of pediatric expertise that we have in the city. And that's really, I think, in all aspects of our response to the COVID crisis, we have been able to lean on some brilliant medical minds in both medical centers and in the 2 community health centers to help us get through this as relatively well as we have. It's not over yet. And that's why we're having this discussion, obviously. But what I'm here to talk to you about is ask for your help. That's what I've pretty much been doing for the city. I've been trying to coordinate the responses of the medical centers and our first responders, and also trying to get word out to the community how we can all help each other mitigate the crisis and avoid us getting flooded with patients in the hospital setting, patients in the doctor's office setting, and confusing us. And it's very easy to be confused when a child comes in with a febrile illness, in other words, a fever, and they may or may not have quote unquote cold symptoms. Now in this age of COVID, is that what they have? Well, one of the things that's going to be very, very tricky for us coming up in the late fall, early winter is flu season. When flu normally attacks, we have a whole raft of patients that come in pediatric offices, and of course their parents in adult practitioners' offices with these symptoms of flu, like fever, cough, and runny nose, sometimes GI symptoms like diarrhea and vomiting. The way we can help each other as a community is to really push to get vaccinated against the flu. We don't have a vaccine yet for the COVID virus. We're hoping that will occur, that we will have that vaccine sometime early in 2021. We have a plan within the Department of Public Health for emergency distribution once we get that vaccine. But in the meantime, if we can make sure that the flu cases that we see are fewer, or if we can't totally eliminate them, milder, then we will really be confusing and flooding the emergency department with a lot of patients that we can't tell. Do they have the flu? Do they have the COVID-19 virus? And it's going to clog up the system with tests, clog up the emergency department with wait times, expose people longer to possible COVID patients if they really do have a second wave of COVID coming up in the fall. We just don't know yet. So that's what we're going to be really emphasizing with the help of Dr. Benenda and her wonderful nursing team, Deb McGovern, and Mary Beth Miota, and all of the folks that work on school health are going to help us really push to get your children vaccinated. But we would also ask the parents to get vaccinated. We need to see a real herd immunity, meaning about 60, 70% of the community to get vaccinated. And we never achieve that, despite all of the publicity that we do about flu vaccine and how it's much more available now in local drugstores and free clinics and those kind of venues. We never achieve much more than about 35% of the population getting their vaccine done, the vaccinations done. So I'm begging you, I'm asking you, please, when you get the information about how you can get your child vaccinated, and when you get the information about where you can get vaccinated, talk to your PCP, go to your local drugstore. In the school system, we will be offering the opportunity to get every single child vaccinated. And I wish you take care of your children and your family by getting that done. Take advantage of those services. So
Thanks very much. Thanks very much, Mike. We're going to shift gears now and we're going to move on. We're getting short on time, so we'd like to cover as much as we can. A lot of questions were about screening. And so we're going to start with Lloyd, who's going to give us a little update on why we are or aren't screening. Lloyd, thank you.
Sure. There were a lot of questions about temperature screening. This is something that I know some people in the workplace have had to get their temperature done. When people come into other settings, sometimes they're getting temperature taken before entering the building. The bottom line is that temperature screening has really not been shown to be an effective method of screening who has COVID-19 and who does not. And especially for children, there are a high number of children, in fact, most children who have COVID-19 don't actually have a fever. And the majority of children who have a fever are going to have something else besides COVID-19. So it's just not been shown to be an effective method of screening. In addition, we don't feel that it's worth taking that time. You think about how would you taking the temperature, keeping everyone distance as they're walking in the door in the morning. So to do something that's going to take a lot of time away from our critical education time, which of course we want to maximize, for something that really provides no benefit. When it comes to sort of symptom screening, that there was sort of this other thought about should there be sort of a mandatory daily questionnaire that parents fill out, or some sort of app or some sort of website. Again, you know, this is just not something that is really feasible or logistically possible, and the benefit of it just does not justify the time or the effort that everyone would have to take for doing that, because it has not really been shown to appropriately or accurately identify people, especially young children, who may have symptoms. And this, again, I'll just briefly reiterate what others have said. This is what it comes down to, sort of this community citizenship and this need that we all, whether we're a parent, a teacher, a pediatrician, anybody that's involved with children in the school system, we all need to be very diligent about keeping ourselves and our children home when we are feeling ill, when we have any of these symptoms that are on the symptom list that your school nurses and your pediatrician and their office will have. And don't send your children to school. Don't go to work if you have any of these symptoms. And then I'll move things on to Bev to talk about what's going to happen when a child is in school and develops symptoms there.
I'm going to talk just very briefly here, but as the Worcester school physician consultant, my main role is that I work really closely with our nurses and our nurse leaders in the schools. And, you know, as Lloyd said, we want to avoid having kids in school with symptoms in the first place, but inevitably kids are going to have some symptoms in the school. And so what I just wanted to briefly say is that our nurses and nurse leadership are in coordination with our administration are planning for this, and that they will be cared for, and that our nurses know about COVID. And so if a child is symptomatic, kids will be brought by the school nurse to what we call, it is called by DESI, the medical waiting room. And where they would have to be until they're picked up. That would be an area that where kids are socially distanced, they're spread apart, they're safe, there's someone that's keeping an eye on them. But I just wanted to be able to say that that is the plan. Parents would be called. We realize that it may take a while sometimes for parents to pick up their kids. It's not always easy to have transportation, but that we are working on figuring out all the details of that, and that if your kids have symptoms in school, they will be well cared for. And so I think I will with that just pass it on to Tina, who I think you'll have a lot of questions on are about testing. And what's more interesting than the medical waiting room is what happens once they get home and what happens with testing and that kind of thing. So I'll pass it on to Tina. Thank you.
Thanks, Bev. So what I'm going to do is just briefly summarize the guidelines about that came out from DESI, the Department of Early Childhood and Secondary Education, and understand that these are guidelines, but most schools will be adopting them. And I was very pleased to see these guidelines. I thought they were very reasonable, and I thought they provided a good balance of keeping children safe in the school, but not keeping children home for too long when it was likely very safe for them to return. So we had a lot of questions about what if your child is sick? If your child is sick, this has been talked about, don't send them to school. And likely the fastest way to get them back is to get them a test. And this would be unless there is a clear alternative explanation for their illness. They have allergies or a migraine headache or something that their doctor thinks is clearly not COVID. So if it could be COVID, the fastest way to get them back would be a test. And we're going to be really working on improving availability of the test. We realize this is the backbone to getting kids back to school. If once they get the test, clearly if the test is positive, they need to stay out of school. And we would follow the CDC guidelines for that, which is that they would stay out a minimum of 10 days, but they also have to be fever-free for 3 days and have an improving cough before they could go back. And what we've learned is that people really aren't contagious after 10 days of the onset of their symptoms, if their symptoms have resolved at that 10-day point and they've been 3 days without a fever. If they aren't tested, then they do need to stay out for 14 days. If they are tested and they're negative, then you'll be getting similar recommendations that you would have had last year before the pandemic. Your child needs to be better for 24 hours before they go back. So they shouldn't go back until they've been fever-free for 24 hours and other symptoms are much improved for 24 hours before they go back. Because as Dr. Hirsch mentioned, we don't want kids catching other things that look like COVID because it leads to so many other complications. So keep your kids home if they're sick and if their COVID test is negative for 24 hours. There will be, if there's a positive COVID, there will be something called contact tracing. So the Department of Public Health will help us determine who potential high-risk people are in the school for being exposed. I spent a long time talking, the last question that was sent to me about the fact that this will be relatively low incidence because we don't think this will happen a lot, but we're going to be incredibly cautious and likely if there's a positive child in the classroom or a teacher, the whole classroom would likely have to go to remote learning for what we call that quarantine period, that period of time during which they might develop symptoms. There is an option for them to be tested about 5 days after they've been exposed. And if it's just a one-time, it's just a minimal exposure in that classroom, if they're tested 5 days later, there could be an option for them to return to the classroom if that test is negative. Again, this means we need to work on these tests being readily available, even to children who aren't showing symptoms. So that's just a brief overview of some of those guidelines. The second part of the question was about testing in general. And this is, again, a hot and important topic. There are two ways of looking at the test. People like to use a term called sensitivity, and that is something about the test. How likely is it to pick up the germ? And the numbers that we know about this test, where they either stick a swab up the child's nose or have the child spit into a cup, is about 70 to 95% sensitive. That probably depends on the timing of the test. If you have a sick child, it's much more likely to pick up the test because your child is sick and we're going to pick it up. What's a very important number to think about as well is what we call a negative predictive value. So when your child has a negative test, how likely is it that that test is actually negative? And what that depends on is both the quality of the test, but also what was the likelihood that your child actually had COVID. And that's why these community rates of COVID are so low, are so important. And when we have low community rates of COVID, your child's negative test is very, very believable. And we can put a lot of weight on that, that if the community rates of COVID are low, if there's no one in that child's household who has COVID, and their test is negative, the chance that your child has COVID is going to be over 99%. So we can really trust that test in the right setting. So what we call the negative predictive value of that test. So again, I got a little bit technical, but I want you to know that your child's test is going to be looked at in the full context with the medical professional looking at the likelihood of your child having this disease based on their symptoms, based on their exposure, and your child's test will be interpreted to the best of our ability, and we will not send your child back to school unless we feel very comfortable that that test is accurate. And I have faith that that test will be accurate the vast majority of the time.
Thank you, Tina. I'm going to ask a favor of the school committee. As you can see, we've had a lot of discussion on incredibly important issues. And I would like to ask if we should have to go past 7 o'clock, would that be okay? Because this is your meeting.
That would be fine. Thank you.
Oh,
Don't-
thank
don't
you.
have
Thank-
interpretation past 7 or closed captions past 7, that's all.
All right, thank you. So we will move along then. So the next thing we have up is what happens when what happens, you know what's going to happen all in the fall and in the winter, kids get sick, and they get sick with colds and sore throats and all kinds of things. So I'm going to have, Bev is going to talk about the practical side of this, and these are inevitable illnesses that are going to happen. And what do you do about that? So Bev, please.
Well, I think a lot of people brought up some very good questions that if we're going to say that a child has to stay home if they have a cough, a sore throat, diarrhea, fever, any of these things, won't my kid be home all winter? My kid coughs for 2 months straight. And you know what I'm going to say is I don't have a great answer to that, because I think the reality is right now, while many of these things may not be COVID, we have to treat them like they are. And so in my office, I used to be able to see a kid come in with a cough and be like, oh, I just run in and I check them. Now I've got to put on the whole PPE and that kind of thing. It's just a different time. So I think the reality is that there's a very good chance that we're going to have a lot of kids that are staying home, and that and it may not be COVID, but that if kids are doing what they're supposed to and staying home when they're sick, or teachers as well, there may be a time where we also have to think about pivoting to a remote option. And that's something that that our school district would decide in partnership with the Department of Public Health. So I wish I could say, oh yeah, I have a magic bullet, your cough, you can go back if this happens. But I think that the reality is that this is probably another consideration that we would need to take into account. And so I'm just going to pass it on to Dr. Michael Hirsch on that, because I think there's both questions about what happens, how many cases of COVID before a school closes or a classroom closes. And then also this question of, well, what if we have 70% of our kids absent? Do we do something different? So I'll pass it on.
So thank you very much, Bev. I will tell you, the state has now defined a cluster of COVID outbreak as just 2 cases. That's a very, very small outbreak, but that's how aggressive they want the contact tracing to be activated in the event that just 2 students in your school get COVID tested positive. We would have to do a very, very extensive and quick contact tracing effort to ascertain whether or not we would have to close the school down. That's the advantage of the program that Dr. Benenda put into place of cohorting the students in such a way that hopefully they're in pods that we can potentially close down the pod and not the whole facility. But we've had situations where outbreaks have occurred that we've had to close down a whole factory or an entire retail store because of the number of positives that we were getting. We were just granted at the Department of Public Health a CDC grant, whereby we were able to retain a new COVID public health nurse, a specialist coming up from Atlanta to join us. We have also a contact tracing guru coming up from Atlanta, and we're going to have a new group of contact tracers as well. We're supposedly having their services until April. So I think this will really give us a new shot in the arm in terms of being able to stay on top of the tracing. What happens that I think is very important for parents to know is if there's a COVID positive student that's identified, and we then call that family and tell them and they give us information about who they think their close contacts were. And then we call these close contacts. What we have been seeing, unfortunately, is many times those calls that we make to people go unanswered. They go to voicemail and nobody calls back. We call again, There's a lot of distrust about, hey, we're the government and we're here to help you. I understand that. But I would urge you, if you got a call like that, please answer the call, because this is the best way that we can stop the spread if we identify who the contacts were and if they're symptomatic, and then we can get them tested and we can get the family tested, and that really stems the tide of all of this. So I'll stop there. The only thing I also want to say is it's really important that with the contact tracing that gets done, let the process work. What we have been finding out in the community, out in retail stores, out in factories, out in places where people are working, is when the word gets out, the rumor gets out that there has been a positive patient, somebody will call the Telegram and Gazette, somebody will call put it out on Instagram or Twitter. That's not a help, because that just spreads a lot of misinformation and panic. We have a process that I think works very well, and we don't, as much as we love for people to be informed, the information that you get on Twitter is not the be all and the end all. The docs here are the people that we should be listening to. So don't go calling everybody in the school that you know when you hear one person was out sick, because we don't even know why they're out sick. They could be having the flu. They could be having any other kind of illness that just the rumor mill starts. So that's where I'll stop.
Great, thank you, Mike. So there's also been a lot of questions from parents about specific medical concerns for either their children or themselves. So we were going to have Mary Beth address some of those issues. So Mary Beth, and Bev too.
Thank you. Let me just cover a few specific questions that came to us. So one was, sometimes my child has a cough for weeks after he's recuperating from a cold. Will he be kept out of school all that time? And between some of the decision trees and very clear guidelines that Tina talked about, which helps us know when children are most likely and adults are most likely spreading infection, and the reality that we know as pediatricians and school nurses that children and even adults can keep having a cough for weeks after the illness, the cold has passed. This is why you want to be in close contact with your pediatrician, the school nurse. Perhaps if your school has a school-based health center, the school-based health center and nurse practitioner, they can work together with you to figure out if the cold has passed and there's just a little, itchy cough. That's where having a health professional can help you guide the safe thing to go. And nobody's going to be questioning you when you get that good advice. And we're really working together right now to get all those communication bridges between the school, the school-based health center, the pediatricians, the community health centers, and hospitals, so that we're all talking a whole lot more. And I think that should help a lot. And the more you talk to the school nurse and your own physician, the easier it will be. So you may talk to your physician and they say, yeah, we've talked to you and we feel very comfortable that the child is no longer at risk. And so it's not that we're going to keep your child out for the whole winter. And Dr. Nazarian talked a little bit about that. Another parent asked about conditions that your child has. So something like asthma comes up a lot. It's tough to have asthma yourself or have a child with asthma. So first of all, I really want to get to the point that this is a great time to prioritize excellent control of your asthma. You'll have a better life if your asthma is in good control. And you going to the doctor now and talking about that is a really smart thing before either coronavirus or the flu or just a common cold makes the asthma worse. And obviously for some people, just, the maple leaves may give you an asthma flare up. So really work on controlling the asthma. And a child whose asthma is well controlled is much less likely to get either more sick or sick from longer from any virus, but especially coronavirus. So go ahead, make an appointment to review your child's asthma, what triggers it, and what medications that maybe you should be taking every day or when things get worse. There's something called an asthma action plan that can be really helpful for you as a parent and also for that school nurse. If the school nurse knows that your child has asthma and has that asthma action plan, they can work together with you. Again, if the child's school has a school-based health center, and that's where I got more involved in school health, that make sure to sign up in the first days of this school year so you can have that extra sort of teammate on the team to manage issues like asthma, allergies, migraines, chronic headache, because we can always use extra hands. And you will be receiving, if you're in one of those schools in the city that have school-based health centers, you'll receive a release. And they will also help the school nurses do a really good job of managing all of these risks. And so I want to talk about that. Our chapter of the American Academy of Pediatrics, which every one of us is involved in, we're working on clear guides for doctors and nurses to separate out coronavirus from long-term conditions like chronic cough and how to communicate that with the school. And so we're really working very hard at that. But what you can think of is that we're all a team. That includes you as a parent, your child, the school nurse, the teacher, the school-based health center, and the administration. And we can all work together, and the stronger members those teams are, the most likely we can keep school open and your child and your teachers will be healthy. So we can only do that as a team, and you can do it one-on-one with all of these other members of the team. And I'd like to ask Bev now about her thoughts on the mental health effects of going to school or staying out of school during the pandemic for children.
Thank you. So we had some questions from families about, would it be more traumatic or anxiety provoking for their kids to go back to school with worries about COVID? And I think the question, one of the questions was asked was, would they be better off at home with structure and routines? And I think this is a really good question. And I think as a pediatrician, I am not a mental health professional, but I will say that pediatricians are dealing with mental health issues all day long. And over the last few months, I have definitely seen in my practice more anxiety, more depression, more sleep issues, you know, and kids that, you know, definitely struggling to learn. And so I think we've had to address a lot of that. So I think the question about, you know, that I think there's trauma there with COVID for almost everyone. And for some people, the trauma is going to be more staying at home. And that, you know, so I think that if you're looking at how do we deal with anxiety and trauma, I think that's a very personal decision for you as a family. If you have a really anxious kid, I think that, you know your child best, but you also can, I think, model a lot that it's going to be okay if you believe that overall. And so I think being able to share that with your kids is really important. But I will also say that for a lot of kids, in addition to all the benefits, of course, of learning in school and structure in school and socialization in school, the other thing that we know is the factor that most promotes resilience in children when we're dealing with trauma is having a caring, protective adult in their lives. And for kids, that's both their parents at home, but we also have a lot of caring, protective adults in our school. And so I think for a lot of kids going back to school and having their teacher, having their school nurse, having their school adjustment counselors, having their school psychologists, and on this, the schools can tell me all the people that I'm missing. Those are really important people in the kids' lives and can also be helping kids to deal with trauma. So I think I just wanted to add that part overall. I think there's a lot of talent in the schools that can be, helping to support our kids in dealing with mental health issues and with trauma. And so I wanted to put that out there. And again, as I said when we started this meeting, our goal is not here to tell you what you should do for your child, but to give you as much information as possible to be able to support you in making a good decision that feels right for you. And so I think with that, I will give it back to Dr. Young, who can work on our closing comments, and maybe we'll even finish on time.
Well, I'm very cognizant of the time, and I know that the translators have to leave us at 7. So I want to make sure that we finish up on time for that. So I would like to thank all of you for your commitment to our children, for their education during this really unprecedented time. We're going to continue, the medical advisors here on this call are going to continue to work with Superintendent Benenda and her staff, and we're going to watch and we're going to learn what's happening. So if there is a need and if there is a wish of either the school committee or of the community in general, we are certainly willing to provide these forums if you find them useful and helpful. So with that, I'm going to turn this back to John, and we want to thank you also for your generosity of giving up your meeting time to us. Thank you.
Thank you very much. The panel was outstanding. We certainly appreciate your insight on the virus situation in Worcester. And believe me, as we move forward, we would certainly be looking for more medical information on the virus, and even perhaps having another conference panel if you're all willing to come back again. Anything else on Madam Superintendent?
I just want to thank our distinguished panel of physicians for the time you took to prepare and answer the questions. There were a lot of questions, and I know you grouped them by themes and then answered every single one of them. So I want to thank you for this work, and also look forward to our weekly meetings. I think that Worcester Public Schools is very fortunate. There isn't another district that has a panel of physicians that care about our Worcester Public Schools the way that all of you do. And so looking forward to our continued work together.
Thank you. Any comments from the school committee? Ms.
Yes,
Novak?
Mr. Chair. Thank you. I do think it's important for our families and our teachers to understand that we very much appreciate the work of the medical panel. This is, however, only one of the myriad of groups of experts that we'll be listening to. We are also, I know, expecting to be getting reports, for example, from our facilities staff on HVAC systems. We're very interested in having conversations around the health of the adults who are in our system as well. And I know that the administration is doing a significant amount of work around different kinds of planning, both for remote and for hybrid systems. So I do want to make sure that people understand that this is one of a series of considerations that the committee is taking into consideration as it makes its decisions ahead of next week. That this was one opportunity for parents to hear from those who are most concerned with the medical health of their children. And that obviously this is one of the myriad of things that we'll be considering moving forward. Thank you, Mr. Chair.
Thank you. Anyone else? All right, motion to adjourn. Dr. Friel, please call the roll.
Ms. Biancaria,
Yes.
Mrs. Clancy,
Yes.
Mr. Foley,
Yes.
Ms. McCullough,
Yes.
Ms. Novick,
Yes.
Mayor Petty, and Acting Vice Chair Monfredo.
Thank you very much. Yes, and thank you very much, everyone, for joining in with us today. Motion is
Thank you.
adjourned.
Big deal for them tomorrow. Let's take a shower.